All right, let's move on now to the pharynx and larynx. So we'll be covering the entire larynx today in this lecture. This is the second to last didactic lecture overall in the course. We'll be covering the larynx in totality. This will be the first lecture of two on the pharynx. So we'll be returning to the pharynx in the final lecture after this as we do the nasal and oral cavities. Okay, let's talk about the pharynx a little bit first. Now, orientation is a little bit difficult here because we're going to do, in order to see the pharynx and to look at its internal features, we need to do some very unorthodox dissection. And among the things we need to do is disarticulate the head from the cervical vertebrae so it can be reflected forward. In order to do that first, what we're going to do is to clear the retropharyngeal space. So if you recall right here, this red boundary right here, this right here is pretracheal fascia, and this back here is buccopharyngeal fascia directly posterior to the esophagus and also the pharynx. There's prevertebral fascia here located directly on the cervical vertebrae as well as the muscles associated with those vertebrae. And then there's this potential space located in between the buccopharyngeal fascia and the prevertebral fascia. There's a potential space here. This is the carotid sheath right here, and again, that space is behind the carotid sheath between it and the fascia that's located on the superficial surface of the muscles right there. And so we're going to go in and clear this space right here, and this is the retropharyngeal space, and that's the first step. And I tell you this not only because you might perform this dissection someday, or perhaps not, or have the opportunity to look at cadavers for which this dissection has been done, but also for the purpose of this lecture to get some perspective on what we're looking at, because it can be kind of disorienting. So that's the first thing we do. And then the next thing we're going to do is make some cuts here, along here. Now, these are muscles that are located prevertebrally. There are a couple muscles here located directly anterior to the cervical vertebrae right here. Among these are the longus colli muscles right here. That's the longus colli there. And that's just it's a vertical muscle that interconnects the cervical vertebrae. And then this is the longus capitis muscle right here. So longus colli, let me go back to longus colli. So it's a long muscle. Colli means of the column. What column? Well, it's the cervical column. And so this is a muscle that is exclusively taking its origin and insertion off the cervical vertebrae. And then we have the longus capitis right here, which is a long muscle. It takes its origin off the transverse processes of the cervical vertebrae, especially the upper ones, and it's going to insert on the inferior aspect of the head, thus the longus capitis. Okay, well, the longus capitis has to be cut right about there. It's going to be severed. The longus colli doesn't need to be cut. And we're going to also cut all these other muscles right here. These are rectus capitis lateralis muscles, and we have rectus capitis anterior muscles. Don't worry about it. I'm not going to ask you questions about those muscles, but all of this has to be severed right here. And so that corresponds to a cut right along here. And the next thing we're going to do, after having cleared that retropharyngeal space, which is back here, this is the larynx here, directly behind the larynx, all the way from here and then posterior to the larynx, as far down as here is the pharynx, and then we have the esophagus behind the trachea. And we're basically clearing that retropharyngeal space, which is the space between the cervical vertebrae and the carotid sheath and the esophagus and the pharynx right there along this red line. We're going to clear this space right here, and after having disarticulated up here and cleared this space, we can now take the entire head connected to the cervical viscera right here and take the whole thing and reflect it forward like this, nose to chest. Okay, and what that allows us to do, the end result is the cervical vertebrae are sticking up like a post here without a head on it, and the head is reflected forward. That gives us this view of the cervical vertebrae. We can get a nice clean view of the longus colli muscle and the longus capitis muscle, though it's been cut right there. But at the same time, we also can stand behind the pharynx right here and look this way at the back side of the pharynx and the back side of the esophagus. And that's a perspective we're going to take in the subsequent slides, as if you were to remove the presence of this cervical column right here, stand with your face right here, looking anteriorly at the back side of the pharynx. And so this is sort of what we end up with. The presence of the cervical column has been removed. It's over here somewhere, and we actually can stand in this space and look this way, look this way, look this way. The cervical column had articulated the C1 vertebra, specifically the atlas, had articulated with the occipital condyles here and here. Okay, that's now elsewhere. And what we have now, the head has been detached from the cervical column, hanging from a hinge right here consisting of the cervical viscera, okay, which consists of larynx and pharynx and trachea and esophagus. Also still present here, not shown in the diagram though, in the cadaver, is the carotid sheath and its components. Again, not shown here, but still present following this dissection. So let's look at the organs here. What do we have in terms of cervical viscera? Well, first we have the larynx, which extends roughly from here to here, roughly from the hyoid bone, though the hyoid bone is not technically a part of the larynx. The epiglottis, on the other hand, is. The epiglottis, which we can't see yet because it's deep inside, will extend to right about here. That's included in the larynx. Also included in the larynx is the thyroid cartilage. We might even say the thyrohyoid membrane, which is this right here, the thyroid cartilage and the cricoid cartilage, which we can see right there. That's the larynx right there. The larynx is exclusively a part of the airway, meaning no food is supposed to go in the larynx in an ideal world. And the larynx is going to be continuous with the next part of the airway, which is the trachea right here. That's the trachea right there. Now, on the back side of these organs, so these are cartilaginous organs, okay? The larynx is made of cartilage, thyroid, cricoid, and we're going to see in a little bit some additional cartilages. The trachea also consists of cartilaginous rings. Now, on the back side are some additional cervical viscera that are mostly composed of muscle, okay? We have the pharynx, which extends from way up here all the way down to this point here. So a portion of the pharynx is directly posterior to the larynx. Another portion is going to be posterior to the oral cavity. And another portion is even way up here, going to be posterior to the nasal cavity. So the pharynx extends all the way down to here. And then it's continuous with the esophagus. So after the pharynx, we have the esophagus. And again, this is a dedicated part of the gastrointestinal tract right there. Only food passes in the esophagus. Only air should be passing back and forth within the trachea. Okay, but our perspective again in the future slides here is if we're standing here behind the neck, looking directly at the back side of the pharynx and the esophagus. Okay, and that gives us our perspective here. So all of this is just to set up and get you oriented as to what the heck we're looking at here. And this is it right here. We're looking at the back side of the pharynx and the esophagus without the cervical column getting in our way. And so this is it right here. That's what the pharynx looks like from and back. And again, it looks like a giant muscular, wide muscular tube because that's really what it is. And then it will narrow right here into a narrower muscular tube called the esophagus. We can just catch view right here, the back sides of the right and left lobes of the thyroid gland. Again, we're behind the patient looking forward, so our right is the patient's right and our left is the patient's left. Everything's aligned because we're behind the patient. So I can say this is the right lobe of the thyroid gland, this is the left lobe of the thyroid gland. So we can see those from the back side. Remember, the two lobes are connected to each other via the isthmus, but that's on the other side. That's on the anterior side of the cervical viscera. Over here, we can just catch view of the sternocleidomastoid muscle right here. Mastoid process would be right here, right behind the ear. There's a sternocleidomastoid muscle right there. And we can see right here, this is the jugular foramen, this hole right here. Okay, and it's at the jugular foramen that the internal jugular vein begins. It's going to pass straight out. Artist has cut it off right there so we can see, but the internal jugular vein was going to pass straight down this way, right next to the carotid arteries. We can see right here, we've got internal carotid artery, external carotid artery, and this is the common carotid artery right here. And so remember, the common carotid artery and the internal carotid artery, along with the internal jugular vein, made up the components of the carotid sheath. So we can imagine there had been a sheath right there. Okay? Now, coming out of the jugular foramen are some additional things, 3 cranial nerves. So in addition to the internal jugular vein beginning there, also passing out through the jugular foramen is the accessory nerve, or cranial nerve 11. It's passing out, and you can see it's going to the sternocleidomastoid. From there, of course, it'll send a branch across the floor of the posterior triangle of the neck to the trapezius muscle. We can't see that here, but the first stop is the sternocleidomastoid muscle. Okay? Now, altogether, cranial nerve 11, in terms of tracing its entire path, again, it starts in the upper, very, very, very rostral part of the cervical spinal cord, about as high up as you can. You go up any higher, you're going to be in the medulla. It comes off the cervical spinal cord, and it's going to ascend into the cranial vault via the foramen magnum. That takes it into the posterior cranial fossa. But then it's going to exit through the jugular foramen. So it takes a weird path where it goes inside the head, only to turn around and come back out, having served really no purpose inside the head. And the first target, the first actual thing it innervates, is the sternocleidomastoid muscle. Now, let's look at some other things back here. Again, there's the jugular foramen again, and we can see the beginning of the internal jugular vein. Okay, and then over here, we can see, let's look at the pharynx a little more right here. And the pharynx is basically composed of muscle, and we call these the pharyngeal constrictor muscles. Technically, there's a superior pharyngeal constrictor, a middle pharyngeal constrictor, and an inferior pharyngeal constrictor. I'm not asking you to distinguish between them. I don't think that's really necessary. For our purposes, we're going to refer to them collectively as the pharyngeal constrictor muscles. I think that's fine. Okay, so essentially the pharynx is basically a muscle that sort of contracts at regular intervals, well, not at regular intervals, but in a succession of stages, we'll say it that way, and forcing food down this way into the esophagus. Now, innervating the pharyngeal constrictors is this guy right here. The vagus nerve, or cranial nerve 10, is motor to most muscles of the pharynx. Okay, certainly motor to all these guys, the pharyngeal constrictor muscles. Now, there is an exception. The vagus nerve is not motor to one pharyngeal muscle called the stylopharyngeus muscle. That's the only pharynx muscle, the only muscle of the pharynx not supplied by, for which vagus is not motor. Let's say it that way. Okay, so vagus is motor to the entire, all the pharyngeal muscles except for this guy. Okay. Now we go over here to this side. There's a styloid process of the temporal bone right there. And we can see right there, right next to it, coming from the styloid process of the temporal bone. And we follow this down, and it's going to blend in with the pharynx right there. That's the stylopharyngeus muscle right there. So it's a muscle that starts on the styloid process of the temporal bone, and we'll continue on down and actually insert into the pharynx. And that's kind of an elevator of the pharynx right there, called the stylopharyngeus. Now, if vagus is not motor to this muscle, and it's not, who is? And a muscle that's motor to this muscle is this guy, the glossopharyngeal nerve, or cranial nerve 9. Okay? In fact, that is the only muscle that the glossopharyngeal nerve supplies. The glossopharyngeal nerve is only motor, let me say it this way, to one striated muscle. Okay, it is motor to smooth muscles. Ultimately, we've already said it's preganglionic parasympathetic to the parotid gland. So not saying there isn't a visceral motor component to it. There is a visceral motor component, but this is the only branchial motor component to it. It's only supplying the only muscles derived from a somite or a branchial arch. It's only motor to this muscle right here, the stylopharyngeus. Okay. Now that's not to say that the glossopharyngeal nerve doesn't do very much. It has lots and lots of sensory functions to it. And among the things it's sensory to is the pharyngeal mucosa. So while it's motor to only one pharyngeal muscle, it's sensory to the entire pharynx. Okay, all the mucosa inside the pharynx gets its sensory innervation from cranial nerve 9. And we can see what's happening here. Here comes glossopharyngeal nerve. It too is passing through the jugular foramen, runs alongside and parallel to the stylopharyngeus muscle, innervating it, and then dives inside the pharynx, where it then basically is basically setting up a sensory plexus throughout the mucosa on the inner aspect, the inner surface of the pharynx. That makes it the sensory limb of the gag reflex. So gag is when you touch the back of your throat, okay, and try it and you'll see what a gag is. You'll basically choke on your own finger, or if you even just touch the back of your tongue, that induces a gag as well. Like any reflex, there's a sensory limb and a motor limb, or an afferent limb and an efferent limb. So the afferent limb, or the sensory limb of the gag reflex, okay, the thing that's bringing information back to the brainstem, informing it that something is touching the back of the throat, that's the glossopharyngeal nerve. That's cranial nerve 9. Okay, let's look at some other stuff back here. Okay, also back here we see the sympathetic trunk. So remember I told you there is a cervical extension of the sympathetic trunk or sympathetic chain ganglia that extends up into the neck. Okay, and ultimately if we follow the sympathetic trunk up just deep to the bifurcation of the common carotid, sitting right against the longus colli muscle, which we don't see right here, but if we had the cervical column still in place, the longus colli would be right about here. We see this guy right here. This thing, this long sort of fusiform looking bulge in the sympathetic trunk, that's the superior cervical ganglion. Now people always want to, for some reason, put sympathetic in here, and you don't need to do that. The superior cervical ganglion is its proper name. It is a sympathetic ganglion, but don't stick sympathetic in there as unnecessary. The superior cervical ganglion is the most rostral, the most cranial of all sympathetic ganglia, meaning there are no more sympathetic ganglia above this line right here. Now, the neurons in here, so basically what's going to happen, preganglionic sympathetic axons are going to ascend in the sympathetic trunk and synapse in here. And then postganglionic sympathetic neurons, their cell bodies located here, are going to send their axons into various things. Okay, and among the things they're going to do is send their axons along this thing right here called the carotid nerve that's going to jump on the internal carotid artery. And then those axons, postganglionic sympathetic axons, are going to use the artery to get inside the head. Okay, and that's how we have sympathetic innervation to this side of the head right here. We have another superior cervical ganglion over here, of course, not shown. But that's how we get sympathetic innervation to the ipsilateral side of the head, is coming from this superior cervical ganglion. Okay, there's the internal carotid artery right there. And again, that's what these fibers are jumping on right there to get inside. Okay. Now, this is another opportunity, probably getting a little sick of hearing this, but we can talk about sympathetic innervation of the head and what it supplies. So let's do it again. I already went through this. Preganglionic sympathetic axons from the T1 spinal cord are going to ascend within the sympathetic trunk here, the cervical extension. Synapse here, okay, and then cell bodies within the superior cervical ganglion, they're going to jump their axons into the internal carotid artery, which is going to enter the head. Now, why do we need sympathetic innervation to the head? Well, again, we've covered this before. We've got the superior tarsus muscle, which is an elevator of the upper eyelid. We've got the dilator pupillae muscle, which is going to dilate the pupil. And then in the skin of the face, we've got sweat glands, and we've got smooth muscle of skin vasculature that we want to constrict whenever we're afraid or threatened. And again, this takes us for the umpteenth time to Horner's syndrome. And again, just to remind you what Horner's syndrome is. Okay, a lesion of this sympathetic pathway anywhere along this line and loss of sympathetic innervation to the face is going to be characterized by, on the ipsilateral side, a half mass ptosis, a mild ptosis, the upper eyelid, pupillary constriction because parasympathetic, the parasympathetic division of the autonomic nervous system is driving pupillary constriction, and then loss of sympathetic innervation, the parasympathetic pathway is now unopposed, which means the pupil will be more constricted than it's supposed to be because the sympathetic system can't dilate it. Anhidrosis, which is the absence of sweating, or at the very least hypohidrosis, which is reduced sweating, and then again flushed skin because the vasculature will dilate within the skin. Again, the sympathetic nervous system wants to drive constriction of cutaneous vasculature. And so, again, the vasculature will do exactly the opposite. It will dilate, more blood will flow to the facial skin, and you'll turn red. All right, let's keep going. So let's go inside now. And what we want to do is make a nice midline incision along the posterior midline of the pharynx, okay, right between the left and right pharyngeal constrictor muscles, and then open up the pharynx like a book and look inside. And so that's what we've done to one side here to reveal the interior. And there's lots of cool things in here, okay? And then we're going to do it to the other side. So now we've reflected both the right and the left side, and this is the view we get. Now remember, lining the inside of this right here, this is the inner surface of the pharyngeal constrictor muscles right here. This is pharyngeal mucosa. So when I told you cranial nerve 9 is sensory to the pharyngeal mucosa, I was talking about this stuff right here. So anything that comes into contact with this mucosa here and here is going to stimulate cranial nerve 9 and induce a gag. Okay, but let's look at some of the things we see in here and just get some perspective. This is the larynx right here. Okay, there's the larynx. This right here, what we've opened up, is the interior of the pharynx. If we continue on down, we're going to continue on down and inside the esophagus. So you can see the opening of the esophagus right here. Larynx is in front of the pharynx down here from here to here. We're going to dissect this conceptually in a little bit, the larynx. Right here is the back of the tongue, okay, more formally called the root of the tongue. That's what we're looking at right here, the back or root of the tongue right there. This is the uvula right there, okay, hanging off the soft palate. This is soft palate right here, and there's the nasal cavity right there. We're looking at the inside of the nose from posterior to anterior. Okay, so that's what we're looking at right there. So from the interior of the pharynx, you can see lots of things. Nasal cavity, oral cavity, looking at the back of the tongue. So if we go in there far enough, we'll find teeth. And there's the larynx right there. Okay, so I already told you this is the uvula right here, hanging down off the soft palate. Okay, and then this thing sticking up right here, that's the epiglottis. It's located directly behind the tongue right there, and that's sort of the tippy top of the larynx right there. It's just this little flap right here. We'll talk more about that when we deal with the larynx. Okay, and then what we're going to do is use these two landmarks, soft palate with the uvula and the epiglottis. We're going to use these as boundaries to subdivide the pharynx into three components. So really, there's not one pharynx. I mean, there is one pharynx, of course, but we're going to subdivide it into three parts. Okay, and so properly, we should refer to this green region down here, okay, this blue region, and this red region right here. And each part of the pharynx is named for what's directly anterior to it, what's in front of it. And so down here, if we're kind of below the epiglottis, as far down as the esophagus, if we're kind of right in here, this portion of the pharynx is more properly referred to as the laryngopharynx or laryngopharynx. Okay, this part of the pharynx is directly posterior to the larynx, making it the laryngopharynx. Okay, here, circled in blue, this part of the pharynx is directly posterior to the oral cavity. I know that because I'm looking at the back of the tongue right there. And so this part of the pharynx is more properly referred to as the oropharynx. It is the pharynx, or that portion of the pharynx, that's directly posterior to the oral cavity. And then, so here, that oral pharynx here, note, is between the epiglottis, it's above the epiglottis, and below the soft palate and uvula. If we go above the soft palate and uvula and look at this portion of the pharynx right there, that's the nasopharynx, because it's posterior to the nasal cavity. So that's how we subdivide the pharynx, and we'll deal with the anatomy of each of these sections one at a time, more or less. But we want to take the pharynx and divide it into three parts, using the epiglottis and the soft palate as delimiters. So now let's talk about the larynx a little bit. So we're going to take a departure from the pharynx, but we'll come back to the pharynx because we've got the pharynx has some additional features that we need to take into account. And we'll spend some time looking at the larynx. Okay, the larynx is basically a valve, essentially, that exists between what exists below that, which is part of the larynx, as well as the trachea, bronchi, and lungs, and that portion of the airway that's above the larynx, which is essentially the oral pharynx, the oral cavity, nasopharynx, and the nasal cavity. And basically it serves several functions. So like any valve, it's going to regulate something. It's going to regulate the flow of something, in this case airflow, to and from the lungs. Now why would we want to do that? Well, for one thing, we there are certain times where we want to trap air below a certain level and let pressure build up and then release that air very, very suddenly. And so among the reasons why we want to do that is to cough or to sneeze. So coughing, the purpose of coughing is to free some debris or something that's landed on the mucosa of the larynx or the trachea that doesn't belong there. And that's what a cough is. A sneeze is to rid ourselves of some debris or something that's touching the nasal mucosa that doesn't belong there. Either way, we need to trap air deep below the larynx and then let pressure build up by increasing our intra-abdominal pressure. So we're going to build up pressure and then we're going to release that air very, very suddenly. And the idea is that we're going to blow off whatever happens to have landed on the laryngeal or tracheal mucosa and blow it out, or whatever landed in the nasal mucosa, we're going to get rid of that by blowing that off and out of our nose. That's what a sneeze is. We also need to increase intra-abdominal pressure for a number of other reasons, and trapping air below the larynx helps with this. And we already talked about how the abdominal muscles are useful for these functions, but trapping air deep also helps. Okay, so basically the valsalva, micturition, defecation, parturition. Anytime we're trying to push something out of our bottom, basically, this can help with that. The other purpose of the larynx is to protect the airway during swallowing. We want to make sure that any food goes down the right pipe, and the larynx is going to play a key role in that. And then, of course, we got talking. Okay, more specifically, phonation is mediated by the larynx. Now, phonation is the part of speech that is generated by vocal cord vibration. The vocal cords are components of the larynx. They will vibrate as a part of speech. Now, there are other components of speech that the larynx is not involved in, and those are things like articulation and resonance, which involve all of this anatomy right here. All these things got to work together to produce recognizable speech. We need phonation, articulation, and resonance. And I'm not going to deal much with this stuff right here. Just understand the purpose of the vocal cords are to vibrate a particular pitch for the first component of speech, which is phonation. Okay, so where's the larynx? It's right here. That's it right there. This is the epiglottis sticking up right there. Okay. And then there's an opening right there. This is an opening into the larynx right there called the laryngeal inlet, or you could call it the laryngeal adytus. An adytus is a hallway. Okay, it's not much of a hallway. It's really more of an opening right there, but that's it right there. It's not perfectly horizontal or vertical opening. It's more of an oblique opening. So when you look at the front end of the opening, it's kind of high. The back side of the opening is kind of low. So it's kind of obliquely oriented, but that's it. That's the opening into the larynx, which is down here. And that's different than the laryngopharynx. And the whole idea is that we don't want food going into this hole. We want to steer it out here, this way, through the laryngopharynx, through these little spaces here called the piriform recesses. Don't worry about that, but that's what these are called right there, and then into the esophagus. And so a big part of this right here, what the larynx is doing is guarding this entranceway, not allowing things to go in. Okay, and the epiglottis will fold over whenever we swallow. The epiglottis will fold over partially posteriorly. It doesn't completely close off the laryngeal inlet, but it closes it off just enough to steer food laterally through these piriform recesses. Food's going to go this way, steer clear of the laryngeal inlet, and end up going into the esophagus where it belongs, and then onto the stomach. Okay, but that's a laryngeal inlet or adytus. Okay, now, in dealing with the larynx further, we need to kind of break down its skeleton a little bit. And by skeleton, I'm mostly talking about cartilage here, really no bones. The hyoid is a bone, but formally it's not really technically a part of the larynx, but it does have an important relationship with the larynx. You can find it right there at the superior end of the larynx. But otherwise, what else do we have here? We have a number of cartilages. And so this is an anterior view of the larynx right there. And so this is the view we've already got in here. And you can see a number of things here. This is the thyroid cartilage right there. These are cartilages that are ghosted in. It's like if we had x-ray vision and could look through the thyroid cartilage, you would see these guys. So don't worry about these guys yet. Pretend you can't see them. This is thyroid cartilage right there, shaped like a shield, okay, because that's what thyroid means. It means shield. Okay, and between the thyroid cartilage and a hyoid bone, there's that thyrohyoid membrane we talked about. Remember, the internal laryngeal nerve is going to pass through an opening, probably this opening right there, as does the superior laryngeal artery, also pass through an opening in the thyrohyoid membrane to get inside. But that's the membrane right there. And then way down here, we have a cricoid cartilage right there. There's this little ring right here. And below that, this is in larynx. This is trachea, which is a separate thing. Now, if we look at the larynx from the side here, oh, by the way, I forgot to mention the epiglottis here. There's the epiglottic cartilage kind of sticking up right there. And again, normally you can't see it because the mylohyoid muscle would be in the way right here. Not to mention skin, but that's the epiglottic cartilage, and that's very much a part of the larynx as well. Now, looking at this from the side, okay, same components, but I want you to get an appreciation for how they're shaped. Again, there's the epiglottic cartilage sticking up just above the hyoid bone. There's our thyrohyoid membrane. And then there's our thyroid cartilage, this time from the side. And you see as you work your way back, it's got these little horns, a superior horn that sticks up and an inferior horn that sticks down. And we'll see in a second, a little bit, there's going to be a little working joint right here between this inferior horn of the thyroid cartilage and the cricoid cartilage. The cricoid cartilage, note something, what's happening here. It's really, really kind of short in front. But as we start working our way to the back side of it, notice it's getting taller and taller and taller. It's actually tall in back, kind of short in front. Okay, so that's the side of the cricoid cartilage. You can kind of see its shape right there. Okay, so it's kind of short in front, tall in back. And then we look at the back side of the larynx. Okay, and this is what we see. There's the epiglottic cartilage sticking up. It looks like a leaf kind of sticking up right there. Okay, it's attached to the inner aspect of the thyroid cartilage, which is this thing. The thyroid cartilage is V-shaped if you look at it from above and look down. So it's kind of V-shaped. These are called the laminae. This is the lamina of the thyroid cartilage, the left lamina, that's the right lamina. They meet in a midline, but you can see the thyroid cartilage is open and back. Okay, those are those horns again, superior horn and inferior horn. And then back here, you can see there's the cricoid cartilage right here. That's trachea down there. Okay, the tracheal rings only go around about 270 degrees, just around the front side, and back it's replaced by a membrane. The esophagus is right behind this. But there's a cricoid cartilage from the back side. You can see it's really, really tall in back. In fact, if you remember, it's thin in front, or short in front, and tall in back. It kind of looks like a ring you might put on your finger with a big front part on the top of your finger. In fact, cricoid means signet ring. So a signet ring is a ring you use to sign things with. So way back in the olden time days, the Pope, for example, had these things. Any kings and queens had these things. And remember, they would close letters by putting a little droplet of wax on the envelope. And then you would take your ring, which has some special symbol on it that is a symbol for you, whether you be the Pope or a king or a queen or an emperor or some other important person, and you push your ring into the wax, and that way you're signing the letter, basically signifying that you closed the letter yourself using your little signet ring, which has a little emblem in here, which is your signature. And so that's what a signet ring is. And to early anatomists, this thing looked like basically the shape of a signet ring. That's what cricoid means, I believe, in Greek or Latin. Who cares? One of those two dead languages. Anyway, you don't need to know any of that. I'm just telling you what cricoid means just to make it fun. But also what a signet ring is. We don't do that anymore. Okay, that's a cricoid cartilage anyway. And then, right here, you can see sticking up, sitting on top of the cricoid cartilage right here, there's another cartilage right here called the arytenoid cartilage. There's two of them. There's a left one and a right one. Remember, we're behind a patient, looking at them from behind, so our right is their right. Their left is our left. Okay, Okay, these are the arynoid cartilages, and they're just sitting right on top of the cricoid cartilage. There's some additional cartilages here that I'm not going to ask you to know. These little guys up here, it's not that important. I just want you to know the arynoid cartilages, cricoid cartilage, thyroid cartilage, epiglottic cartilage. Those are the main cartilages I want you to know of the larynx. 3 of them are unpaired, epiglottic, thyroid, and cricoid, and the arynoid cartilages are paired cartilages. And then, right there, you can see, going forward right there, attached here to this part of the arynoid cartilage, and then going directly anterior, ultimately attaching to the inside of the thyroid cartilage, these are the vocal cords right there. If I slap mucosa and a bunch of muscle on top of them, they become vocal folds. So really, I should call these vocal cords. Actually, to be really precise, these are called vocal ligaments at this point. And again, we're going to put some mucosa on top and some muscles, and that's what will make the vocal folds. I'm not really concerned that you make the distinction right now. I just want you to appreciate the famous vocal cords. That's them right there. These are the vocal ligaments of the vocal cords strewn between the arynoid cartilage and the thyroid cartilage. That's a paired structure as well. We've got a left vocal cord and a right vocal cord. Okay. Now, what does the larynx really do? Okay, well, it's actually much more complicated than you might think. It's actually capable, or at least components of it, are capable of a lot of movement, okay, because we need to manipulate the vocal cords. And so, first thing we see, there are actually 2 working joints in this thing, 2 pairs of joints, I should say, and one of them is right here, and also right here. These joints right there, this is it from the side, and this is a joint that's located between the cricoid cartilage and the thyroid cartilage. It's a working joint right there. And what can happen is that the thyroid cartilage is capable of tilting forward and back. Not a lot, I'm exaggerating. It's just the slightest little tilt, maybe from here to there. This thing can turn a little bit at this joint right there, and it can tilt just the slightest little bit forward and then tilt back if it wants at this cricothyroid joint. Okay, so that's one joint. Okay, so that takes us to a muscle, okay, because muscles act at joints. So some muscle must be moving the thyroid cartilage at this joint, and indeed the name of that muscle is the cricothyroid muscle. It's this guy. And this is a muscle we've already seen from the anterior side when you're doing the anterior triangle and you were looking at all those infrahyoid muscles. Some of you asked about this little tiny muscle here between the cricoid cartilage and the thyroid cartilage. And so this is a muscle that's capable by contracting. The insertion is the thyroid cartilage. The origin is the cricoid cartilage, which means the thyroid cartilage is the part that moves. When this muscle contracts, it actually tilts the thyroid cartilage forward just a tiny little bit. Well, why? Why in the world would we possibly want to do that? Well, to put tension on the vocal folds. Okay, so that's a arynoid cartilage right there, and a vocal ligament right here, which is sort of the, you might think of it as the skeleton of the vocal fold. It's attached to the thyroid cartilage in front, attached to the arynoid cartilage in back, and the arynoid cartilage is sitting on the cricoid. Now the cricoid sits still. It doesn't move, and the arynoid cartilage in this particular case doesn't move as well. It just sits there. But what moves is the thyroid cartilage. It moves from here to there. And what that does is put tension on the vocal cords, okay? And tension on the vocal cords is something that we sometimes want to do. Don't ask me why. We're starting to get into the harmonics of phonation of speech, and that is something that is very much outside my scope of expertise. But it's not too hard to imagine that there are cases where we want to put a little bit of tension on our vocal folds to change the pitch of our voice, to talk like this maybe. I don't know. I don't know if our pitch goes up or down when we put tension on it. Something you can look up. I'm too old and lazy to do it. You can look it up on your own time, but sometimes we're going to put more tension on it. Sometimes we want to relax it and put less tension on it, and that's going to change the pitch of our voice. Okay, that's all I'll say about it. We need a tensor of the vocal cords is the point. Muscle needs a nerve supply, and indeed, the nerve supply is the external laryngeal nerve, or more formally and properly, we should call this the external laryngeal branch of the superior laryngeal nerve, which in turn is a branch of the vagus nerve. But I'm happy with external laryngeal nerve. If you know that, I'm good with it. Now, this guy is ultimately, again, a branch of the vagus nerve by way of another nerve. Okay, we'll say that. Okay, we'll come back to this central concept of vagus innervation of the larynx at the end here. Okay, but that's the external laryngeal nerve supplying the cricothyroid. That's the only thing the external laryngeal nerve does. It has one reason for existing, and that's to be motor to the cricothyroid muscle. Okay, now that's our cricothyroid joint and why we need it. Now we've got another joint here and here between the cricoid cartilage again, but this time between the cricoid cartilage and the arytenoid cartilages. The other one was between the cricoid cartilage and the thyroid cartilage. Okay, so these are the cricoarytenoid joints here and here. What happens at those joints? Well, a whole bunch of things. Okay, these arytenoid cartilages, I told you in the previous slide, they don't move when the cricothyroid muscle contracts and puts tension on the vocal cords. That's the thyroid cartilage that moves. But all other manipulations of the vocal folds, we're going to manipulate the arytenoid cartilages, and these guys are highly mobile. They can move in 3 different directions. There's 3 degrees of freedom. They can move from side to side, medially or laterally, so they can slide this way, so they can slide towards each other, and they can slide away from each other. This guy can slide this way while this guy slides this way, or they can slide towards each other. So medial and lateral. Okay, they also can move forward and back. So if we're looking down, this is the thyroid cartilage here. It looks like a little female there because it's kind of blunt right there. Not much of a laryngeal prominence right here. Okay, so we're looking down on the thyroid cartilage. This is the cricoid cartilage here, forming a complete ring, and these are the arytenoid cartilages, left and right. And there's the vocal folds right there attached to them. Well, these arytenoid cartilages can move anteriorly and move posteriorly as well. So they can move forward and backwards as well. And the last thing they can do is they can spin around. Okay, they spin around the vertical axis. So the vertical axis of the arytenoid cartilage is like this, and they're capable of spinning around like this. Okay, so they can move in 3 different directions, and we're going to exploit all those degrees of freedom to manipulate our vocal cords. Okay, now this is just to remind you of these sexual dimorphisms I told you about earlier. Okay, and when we look at these ligaments here, again, the male thyroid cartilage tends to be more, again, mature males, not little kids. Then a mature male, the thyroid cartilage, and again, this is all averages here. I mean, not everybody, it's not all males are the same, and not all females are the same, and not all kids are the same. But in a mature male, usually the thyroid cartilage will elongate and become pointed. Okay, whereas in children and mature females, it tends to be more of a blunt front right there. And this is the laryngeal prominence right there. It tends to be more blunt and shallow in females and children and more pointy in males. And that's the Adam's apple. Okay, everyone's got a laryngeal prominence, a palpable laryngeal prominence. But generally speaking, mature males also have a visible laryngeal prominence. Not only is it palpable, but you can actually see it sticking up and creating a bump in the skin. And that's what we commonly refer to as the Adam's apple, a visible laryngeal prominence. But the other implication of this, we look at these guys. These are the arytenoid cartilages here and here. And these are the vocal cords indicated by VC, going from arytenoid to thyroid cartilage, arytenoid to thyroid cartilage. And we can see the consequence of this pointier thyroid cartilage is that the vocal cords in mature males tend to be longer than they are in mature females and children. And this is what counts for that drop in voice pitch that typically occurs with maturity, particularly in males. But even females' voices will drop, of course. I don't know how many, I don't know if it's an entire octave, but it will drop somewhat with maturity because even in females, the thyroid cartilage is elongating a little bit with normal growth. So everyone's voice drops as they mature, but males generally more than females, and it's all about the length of the vocal cords. The longer vocal cords you have, the deeper your voice is basically the moral of the story. So I'm just trying to explain by this one sexual dimorphism in the thyroid cartilage explains 2 different features of anatomy or behavior, the Adam's apple and voice pitch. Okay, now let's open up the larynx and look inside. So what we're going to do now is make an incision right through here. We're going to cut down through whatever we encounter. And what we're going to encounter, we're going to see a little bit as a muscle right in here. And this is the back side of the cricoid cartilage called the lamina of the cricoid cartilage. We're going to cut down that in the midline as well. And then what we're going to do is we're going to open up, just like we open the pharynx like a book, we're going to grab this, and we're going to open the larynx like a book as well. Okay, and this is what we see when we open up the larynx like a book. Okay, so this was the laryngeal inlet around here, but then we've cut this, and we've cut this, and we've opened it up to look inside. And when we look inside and we see the interior of the larynx, we immediately notice there's actually two pairs of folds. There's a fold here and a fold here. This is with the mucosa still on, by the way, laryngeal mucosa. And this side, they depicted the laryngeal mucosa as having been picked off. Okay, don't worry about that so much. But you can see a fold here and a fold here. This is a right fold. This is a left fold. This pair of folds right here are referred to as the vestibular folds. Okay, and down here we have another pair of folds, one on the left, one on the right. This is the vocal fold, or the vocal cord, or the true vocal fold, meaning that when we talk about phonation, that vibration that's creating speech, like what I'm doing right now, that vibration is actually in these guys, this guy and this guy, not in these guys. The vestibular folds don't vibrate, okay? They just sit still. They're sort of guardians. They help guard the airway below this, but it's the vocal folds. Those are the functional components right there. That's what actually vibrates during phonation. Okay? Got a deal with openings and spaces, and again, this opening kind of coming around like this, that's the laryngeal inlet or laryngeal adytus, and then there's a space between that opening. Right? Talk about openings and spaces, just to be clear here. When you think about a house or a building, a room is a space, and there's an adjacent room, which is also a space. To go from this room to that room, from this space to that space, you're going to walk through a doorway, which is kind of like a two-dimensional opening versus the room, which is a three-dimensional opening. The doorway is an opening. The rooms are spaces, and so that's kind of how I think of this. We go from one space to the next space by passing through an opening. Okay, so the laryngeal inlet is an opening. Okay, and then below that and above the vestibular folds, there's a space. Okay, and that space between the laryngeal inlet and the vestibular folds, that's called the vestibule of the larynx. So it's this space right in here. Okay, and then as we pass down, okay, if I'm in a little airplane, I'm flying this way, I'm going to pass the vestibular fold to a position here between the vestibular fold and the vocal fold. In theory, I can turn my airplane out laterally and fly into a space out here in this dark shadow out here. And there's basically a cul-de-sac out there. It doesn't go anywhere. It's a dead end. But that cul-de-sac out there is another space called the ventricle. Okay, that would be the laryngeal ventricle, just like the ventricles in the brain, but it's not a ventricle in the brain, it's a laryngeal ventricle. And that's what those guys are. They're sort of lateral cul-de-sacs. And again, they don't go anywhere, okay, but that's what is out there. Okay, next, I'm going to pass through an opening. Let's say I don't go through the ventricle, let's say I go this way, I pass my vestibular fold, and then I go right here to a position between my two vocal folds. I'm right in between the left and right vocal fold. I'm now in a slit. There's a slit-like structure, a slit-like opening between the two folds. Okay, the Latin for slit is rima. Okay, and this is the rima glottidis, is what we call this opening right here between the two vocal folds. Glottidis, okay, glottis, Glottis, is a direct reference to the vocal folds. Okay, the vocal cords, vocal folds, same difference. Okay, you can call that the glottis, essentially. Okay, glottidis means of the vocal folds. Okay, and so it's literally the slit of the vocal cords is what rima glottidis is. That's that opening, that thin opening right between two vocal folds. That's the rima glottidis. Okay, don't confuse glottis with glossus with two S's. Glossus is tongue. Glottis is vocal fold. Glottidis means of the vocal folds. All right, and then we go to the next step. Okay, and this down here is another space. After we pass through the rima glottidis, we're now in a space. If I go any further down, I'll be inside the trachea. But right here, I'm in the last space of the larynx before I head into the trachea. And this is the infraglottic cavity. Well, it makes perfect sense. Infra means below or inferior to. Glottic, again, glottis is the vocal folds. Well, where else am I? I'm in a space below the vocal cords. Infraglottic cavity seems like a quite natural name to give this little space right here. And that's it. That's the infraglottic cavity, the space inferior to the glottis, inferior to the vocal folds. Okay? Now, what does this look like in real life in a live patient? Okay, we can't disarticulate the head and bisect the posterior wall of the pharynx and bisect the posterior wall of the larynx and look inside. What's it really look like if we look at it naturally in life? So this is a view from via laryngoscope, looking down somebody's throat, and this is what we see. There's the epiglottis right there, that little flap. The root of the tongue would be right about here. Okay, this is mucosa right here of the oropharynx. Okay, so that's the back of the throat. So if I were to put my finger in here and touch this right here, I would induce a gag. This mucosa right here is innervated by cranial nerve 9, as is the mucosa of all the pharynx. But forget about that right now. Let's go down here. There's the epiglottis right there, that little flap that's overlooking the laryngeal inlet, which I'm circling right there. That's the laryngeal inlet or the laryngeal additus right there. Okay? By the way, epiglottis literally means on top of the glottis. It's hanging out, hovering over the glottis, which is the vocal folds, which are these white guys right here. So we go in through the laryngeal inlet right here, and then we find ourselves inside the vestibule, which is the space right about here. And I see a little pink fold here and a little pink fold there. These are the vestibular folds. The mucosa is well vascularized. That's why it appears pink. The vocal folds are generally poorly vascularized. There's not a lot of vasculature in there. And so the vocal folds, which are the next folds down, these guys appear more whitish. And that's them right there. Also, you'll notice the vestibular folds don't push in as far medially as the vocal folds. Okay, so you can look past the vestibular folds to see the vocal folds. That's it. Those are the vocal folds. Okay. By the way, the rhinoid cartilage would be right here and right here. There, and you see the vocal folds are attached here and go forward to the thyroid cartilage, which is hanging out down here somewhere. That's part of the thyroid cartilage there. There's the other part there. And then right there, that's the slit. Okay, right there, all of this sort of blackness right there, that's the slit between the two vocal folds right there, or vocal cords. And that's that slit right there, okay, indicated by this green arrow here. That's the width of the slit in this particular case. We'll see in a second that that's manipulatable. Okay, that's the rim of glottis right there. And if I keep going past that, way down in these shadowy, scary area down there below the vocal folds, that's the infraglottic cavity. Okay, more muscles, because we got to manipulate the vocal folds, and these are the muscles we need to deal with. Okay, there are muscles in back of the cricoid cartilage right here. Okay, taking their origin off the posterior side of the cricoid cartilage and then inserting here into what are called the muscular processes of the rhinoid cartilages. There's a rhinoid cartilage, and it's got a little spike sticking in back. Those are called the muscular processes. Okay, so it's a muscle taking its origin off the cricoid cartilage and inserting here into these muscular processes. We refer to this as the posterior cricoarytenoid muscle. Okay, so it's going from cricoid cartilage to rhinoid cartilage. And the reason it's posterior is because we're going to see in a moment there's another cricoarytenoid called the lateral cricoarytenoid. There are actually two cricoarytenoids, which is why we got this adjective right here. That's the origin and insertion right there. What does this muscle do? Well, when we look down on this, if we look down this way, this is what it's doing. The muscle is pulling this way. So the cricoid cartilage is here. This is the muscular process, and this is the muscular process of the rhinoid cartilage. And the muscle, when it contracts, is going to pull this way. And that's going to pull in on the muscular processes, essentially adducting them. But we don't care about the muscular processes. What we care about are the vocal processes, is to the vocal processes that the vocal folds are attached. And so essentially what this muscle is doing by contracting and pulling this way, it's spinning the rhinoid cartilage this way and this way. So it's spinning the muscular process in, which spins the vocal process out. And that is going to abduct the vocal cords. it moves them away from the midline. And by doing so, by abducting the vocal cords, it's widening the rim of glottis. Okay? So that thing is going to open up. Vocal cords, which can be sitting right next to each other, are going to move away from each other. Okay? And notice what we're doing. Again, we're pulling in on the backside, the rhinoid cartilage. That's going to pull out. These guys are basically just spinning here in the vertical, along their vertical axis. That's going to spin these guys out. This is important. Posterior cricorhinoid is the sole abductor of the vocal folds. Okay? That's critical. Okay, sole abductor of the vocal folds. That's important because if we can't abduct these guys, if we can't open up this rim of glottis, we can't open up the airway. If these vocal folds slam shut and are right next to each other, the airway is cut off, and then you die. Okay, so we got to be able to abduct these guys to open up the airway to get air in and out. Next muscle, the arynoid muscle, and I'm just going to treat this as one muscle. Technically, there are two different muscles. There's a transverse and oblique arynoid. We're not going to do that. We're going to treat this all as one muscle called the arynoid. And this muscle goes from arynoid cartilage to rhinoid cartilage. It goes straight across like this generally. And when this muscle contracts, the muscle gets shorter. That's going to move the rhinoid cartilages towards each other. So this is not a spinning motion. The two rhinoid cartilages will basically adduct, meaning they both go towards the midline, and you're essentially slamming them together. That makes this an adductor of the vocal folds, because as the rhinoid cartilages slam together in the midline, so too do the vocal folds slam together, and thus they become adducted. And again, this will cut off the airway, but sometimes we need to do this, say, for example, to talk, and I'll talk about that in a little bit, why we want to move these things for different types of behaviors. So again, the rhinoid muscles contract. That moves the rhinoid cartilages towards each other, towards the midline. They adduct, and that in turn adducts the vocal folds, and that closes off the rim of glottis, making it narrower. So this arynoid muscle is an adductor of the vocal folds. Okay, this is what they look like in real life, okay, in a cadaver. Again, here's the epiglottic cartilage right there. Rhinoid cartilage would be there and there. This is the back side, called the lamina of the cricoid cartilage. This is the lamina of the thyroid cartilage here and here. And you can see there's our posterior cricoarynoid, muscle belly taking its origin off the cricoid cartilage and going up and inserting into the rhinoid cartilage right about there. And here we can see the rhinoid muscle. I said there's actually two muscles there. There's a transverse arynoid, and then there are these oblique arynoids. Don't worry about it. So there's kind of a crisscross pattern and also a transverse pattern. We're going to take this and collectively refer to it as one muscle called the arynoid. That's good enough for us. Another muscle, lateral cricoarynoid. I told you there was another cricoarynoid, but the same way, this muscle takes its origin off the cricoid cartilage and inserts into the rhinoid cartilage. But this time it does it from the opposite direction, whereas the posterior cricoarynoid took its origin here and inserted into the muscular process here. This guy takes his origin, lateral cricoarynoid takes his origin off the cricoid cartilage here and inserts on the muscular process from the opposite direction. And so when it contracts, it's going to pull the muscular process forward, okay, and this one forward. And that too, like the posterior cricoarynoid, spins the rhinoid cartilage along their vertical axis. But this time they spin in the opposite direction. The vocal processes here, to which are connected the vocal folds, spin towards each other. By spinning out the muscular processes, the vocal processes spin in, and that too is yet another adductor of the vocal folds. So the vocal folds will slam together in the midline, thus adducting. Note here, it's important, it leaves a little space in back here, and we'll see why that's important in a little bit. A little space is left in here. That makes it different than the arynoid muscle, which does not leave that space. Okay. Here's what they look like from the side here. This is a side dissection. There's our posterior cricoarynoid, okay, going from here to here. There's the lateral cricoarynoid right there, and there's our rhinoid muscles there. Vocal ligaments, so the vocal fold would be right about there. There's an extra little muscle here called the vocalis right there that runs parallel to the vocal folds, but also another muscle called the thyroarynoid muscle that runs, that's probably mostly what we're seeing here, runs from thyroid cartilage, which has been cut right there, to the rhinoid cartilage. Okay, that takes us to this muscle. This is the thyroarynoid, takes its origin off the thyroid cartilage and inserts into the rhinoid cartilage right there. When this muscle contracts, it's going to pull the rhinoid cartilage forward. It's going to pull it anteriorly. So the two rhinoid cartilages are going to move from here to here. They're moving anteriorly. And what that does, by pulling the rhinoid cartilages forward, is the exact opposite of the cricothyroid muscle. These guys are going to relax the vocal cords. By shortening the distance between the vocal processes of the rhinoid cartilages and the front of the thyroid cartilage, it allows these vocal folds to relax and become more floppy. There's less tension on these guys. Okay, and so this is an important relaxer of the vocal folds. Okay, and that's going to change the pitch as well, in ways I don't quite understand because I don't want to get too deep into the harmonics. All right, now, why do we want to move the vocal cords at all? What's the point? Well, this is why. We have a whole bunch of different functions here, okay, that we need to perform. During normal respiration, kind of the resting position, if we're just sitting quietly, just breathing, not talking, just breathing, we want to be in this position right here. Okay, kind of a rima glottis that's sort of moderately open right there, but we do definitely want a rima glottis that's open. Okay, now let's say we're jogging, we're running. What we really want to do is open up that airway wide. We really want to open our rima glottis so we can get air in and out. Okay, and so we want to abduct our vocal folds widely right there. So we want to make heavy use of our posterior cricorhinoid muscles, open these guys up, which allows large amounts of air to go in and out. During normal phonation, normal speech, this is actually what we want to do. We actually want to adduct our vocal folds and our rhinoid cartilages, slam everything together in midline, and create a very, very narrow rima glottis. And so as air is forced through that rima glottis, that's very, very narrow, it's going to cause these guys to vibrate like crazy, which is exactly what I'm doing right now. This is the position I'm in right now as I'm talking to you nonstop, not stopping for even a second. I'm like this, okay, and my vocal folds are vibrating like mad so that I can produce speech. Now, if I keep this up much longer, I'm going to pass out because I'm having trouble breathing at this point. This is the reason why it's hard to talk and talk and talk and talk and breathe at the same time. This is why it's hard to talk and jog at the same time, because the talk, we need to close up our airway. Okay, talking and breathing are contradictory functions. They're conflicting with each other. It's hard to do both at the same time. Okay, and that's why you start to lose your breath when you keep talking and talking and talking. It's why it's hard to talk when you're in jog at the same time or run on a treadmill. Okay, we're trying to serve two different functions at the same time. Now, whispering, what we want to do is open up a little space in back here, and that's what that lateral cricorhinoid is doing by adducting the vocal folds here, but leaving a little space in back. We're leaving a path of low resistance back here for a lot of air to pass through, but bypassing the rima glottis. Okay, it's going to pass through this space instead. And because a lot of air is passing through, bypassing the vocal folds, it allows us to talk like this. So the intensity of speech is going to be reduced as a result because only a portion of the air we're breathing is passing through the rima glottis. So basically it's reducing the intensity of speech. So that's how whispering is done. Here are some real laryngoscopic views of the larynx. So there's a resting position right there. That's deep breathing right there. In fact, you can see the trachea down there practically. These things are so heavily abducted. That's a fishbone right there. Ouch. Okay, let's look at some functional aspects of the larynx. Coughing is basically mediated in the following way. So the vestibule of the larynx in particular is especially sensitive to foreign objects. So basically something lands in the mucosa of the vestibule, we're going to produce a cough. And the whole idea is to trap air below the vocal cords and then release that air, high pressure air, very, very rapidly. And hopefully that blows whatever has landed on the mucosa off and blows it upward toward the nasal and oral cavities. And so there's a marked abduction of the vocal cords to allow for a gasp of air. Basically, we're going to swallow a large gasp of air. And then the muscles are going to contract to close off. Muscles are going to contract to close off the rima glottis. We're going to use our adductors to close the rima glottis, and then we're going to increase thoracic pressure. And then it's going to be sudden abduction of the vocal folds and that's going to allow that trapped air to erupt as a cough. So that's basically what coughing is. Micturition, defecation, and parturition, basically we're going to close off our rim of glottis using our adductors, and we're going to use increased intra-abdominal pressure. We're going to use our abdominal musculature to increase intra-abdominal pressure, and then we can perform these three functions. Now let's look a little bit at the nerve and blood supply of the larynx right here. And the thing to understand is that the nerve supply to the larynx, all of it, muscular and sensory innervation of the larynx, is all mediated by the vagus nerve. The vagus nerve is the nerve of the larynx, okay? And so here's the vagus nerve right here. It's just come out of the jugular foramen. And it's going to give rise to something called the superior laryngeal nerve right here. The superior laryngeal nerve, in turn, is going to give rise to two branches. There's an internal branch and an external branch, which we can call the external laryngeal nerve. That's perfectly fine. And that's going to go down and innervate that cricothyroid muscle again. Remember, that's the tensor of the vocal cords. That's that muscle that can rock the thyroid cartilage forward at this cricothyroid joint right here. And so again, the nerve supply of the cricothyroid is the external laryngeal nerve. The internal laryngeal nerve, or the internal branch of the superior laryngeal nerve, you can call it either one. I'm allowing you to get away with internal laryngeal nerve because it's shorter. So again, that's also a branch of vagus. Remember, that's that nerve I told you about earlier when we did the anterior triangle of the neck that pierces the thyrohyoid membrane. And that's going to take it inside the larynx, where it's going to be sensory to the mucosa of the larynx above the vocal folds. And so this is a sensory nerve. Okay, and there it is right there. So we're looking at the inside of the larynx, this time again from the posterior side, to get oriented. Okay, this is the root of the tongue over here. This is the epiglottis. That makes this the laryngeal inlet. This is thyroid cartilage here and here, cricoid cartilage here. And there's our muscles. We got a posterior cricorhinoid. Here's our rhinoid muscles there. And you can see, again, this is thyroid cartilage. Hyoid bone you can just make out there. That makes this thyrohyoid membrane. And there's our internal laryngeal nerve piercing the membrane right here, and it's going to go in and then go deep to this tissue right here, ultimately innervating the mucosa of the vestibule of the larynx, and it's going to be sensory to that mucosa. Okay, and it's accompanied, don't forget, by an artery. That's the superior laryngeal artery. Okay, so it's the same two structures we talked about piercing the thyrohyoid membrane earlier. This is what the internal laryngeal nerve does. It's ultimately sensory to this mucosa right here. And so it's going to be sensory, it's going to be the afferent limb of the cough reflex. Okay, so it's sensory to the all the laryngeal mucosa, superior to the vocal folds, which would be right about here. All this mucosa right here, sensory innervation of that mucosa is the internal laryngeal nerve. Okay, so damage the internal laryngeal nerve. If we were to somehow damage this nerve, you would have a diminished cough reflex, especially on that side. So if we were to damage this one right here, and let's say some debris landed on a mucosa right there, you might not get a cough, and that would be bad because whatever's in there doesn't belong there. So you would have trouble coughing that up. Okay, so that's what happens with damage to the internal laryngeal nerve. Okay, there's another nerve, and this is a nerve that we're well familiar with. This is the recurrent laryngeal nerve. We have a left recurrent laryngeal nerve. Remember, that was the one that was hooking around the arch of the aorta, coming off the vagus. And here on the right side, here's the right vagus coming down. And the right recurrent laryngeal nerve is going to hook around the right subclavian artery. And both of these nerves on either side, here's the right recurrent laryngeal nerve. On the other side, okay, we have the left recurrent laryngeal nerve. They're going to ascend basically in a groove between the trachea and the esophagus. The esophagus would be over there. We can't see it. And it's going to ascend up that groove, heading right for the larynx. Okay, and this is it right there. So there's the recurrent laryngeal nerve here entering the larynx by passing up between the trachea and the esophagus, which we don't see. The esophagus is directly behind the trachea, directly posterior to it, and it's going to enter the larynx right there. The cricothyroid joint is right here, and officially the recurrent laryngeal nerve is going to change names right at this point to the inferior laryngeal nerve. Quite honestly, that's one of the more mood and nugatory points in all of anatomy. I don't really care that that's a critical learning objective that you take away from this. we can just as easily call this the continuation of the recurrent laryngeal nerve. This is the one everyone makes reference to, and that nerve is going to come in, and you can see what's happening. The recurrent laryngeal nerve is going to be supplying all of these muscles. It's motor to the posterior cricoarynoid, it's motor to the arynoid muscles, and quite frankly, it's motor to every other muscle of the larynx that we listed off earlier, except for that one muscle on the outside, the cricothyroid. That's that muscle is done by the external laryngeal nerve. Recurrent laryngeal nerve, technically the inferior laryngeal nerve, but who cares? That's motor to everybody else. And so this is the major motor nerve to the larynx. Okay? I just said that. Motor to everything, every single laryngeal muscle on the inside of the larynx. The cricothyroid is the one muscle that hangs out on the outside. All the internal muscles of the larynx, every muscle except for the cricothyroid. Okay? So what happens, and this is important, unilateral damage to the recurrent laryngeal nerve, if we damage one of them, the patient will have a hoarse voice, pretty much probably for the rest of their life. It results in a hoarseness of voice. This is why neck surgeons and thoracic surgeons are paranoid about the recurrent laryngeal nerve. And whenever they're in there operating, either in the neck or the thorax, they're worried about hitting this nerve, because if they hit it, they know their patient's going to wake up from that operation with a hoarse voice, and it's probably going to stay that way. Okay, now bilateral damage to the recurrent laryngeal nerves, if somehow you damage both the right and left recurrent laryngeal nerves, okay, this guy is motor to the posterior cricoarynoid, which I told you earlier is the sole abductor of the vocal folds. And by default, the vocal folds will adduct. And so if you paralyze this muscle on both sides, the right and the left posterior cricoarynoid, the vocal folds will slip into a default adducted position, and the airway will be obstructed. And that is potentially fatal. Okay, so that's a potentially fatal condition, bilateral damage to the recurrent laryngeal nerve. That's a pretty rare occurrence. It's pretty hard to imagine how both recurrent laryngeal nerves can both be damaged. Okay, there's just a cadaveric dissection of it. There's our recurrent laryngeal nerve coming up. Right about here, it turns into the inferior laryngeal nerve, but again, not terribly concerned about that. There's the internal laryngeal nerve coming in after it's pierced the thyrohyoid membrane. Okay, in terms of blood supply, we're just trying to kind of mopping up things we already talked about. You already know about the superior laryngeal artery. That's that branch that comes off the superior thyroid artery, pierces the thyrohyoid membrane, and that's going to be the blood supply to the larynx above the vocal folds. And then we've got this thing called the inferior laryngeal artery, which, as you recall, is coming from actually, I don't think I've talked about it before. The inferior thyroid artery came off the thyrocervical trunk, that same artery that gave rise to the transverse cervical artery and the suprascapular artery. Well, he, in turn, gives rise to an inferior laryngeal artery. So it's kind of cool. Superior thyroid artery is giving rise to the superior laryngeal artery. Inferior thyroid artery, which comes off the thyrocervical trunk, that's giving rise to the inferior laryngeal artery, which is the blood supply to the larynx below the vocal cords. Okay, that's it. That's the first. Again, handle a little bit of pharynx here. We'll revisit the pharynx in the final lecture, which is the next one. And that's it for the larynx. Again, as always, let me know if you have any questions.